going to talk about electrolytes, kind of an internal medicine-y, nephrology kind of talk, but I have to tell you, the electrolytes that we deal with in the ER are kind of fun. They're kind of interesting, they're kind of fun, and this isn't a super long talk, but it hits things that we see very frequently. And most of the things with electrolyte disturbances that we see, we can do more harm than good by making somebody euboxic. So there's a term that came out of that book, The House of God, which is euboxic. Every box is normal. You make it normal, the vital sign box, the labs boxes. You make it normal to make you feel better, but it isn't necessarily the right thing to do for the patient. And that in electrolytes is a very common problem that we'll talk about as we go through this. And well, all it is your body has cations and anions. It has positive things and negative things. It has your sodium and your chloride. Everything balances itself out for the most part, keeps you from sparking. And each of these electrolytes has its own set of rules. Some of them tend to go together. We'll talk about that. Potassium and magnesium should be thought of in the same synapse. Okay, those two like each other. Those two go together. You need to often supplement both of them if they're down for either of them. So some of these electrolytes kind of work together, but some of them have their own rules, particularly potassium and sodium in particular. So let's go through the disorders. And we're going to start with the human salt lick. We're going to start with the person that comes in often from the nursing home or somebody who's a psych patient or a child where they don't realize that they're getting super, super dry. And you've all seen the person who comes in altered from the nursing home with a sodium of 170. It's like, holy Toledo, 170. Usually it's a dehydration problem. It's pretty hard. If you think about it, I don't care how much you like potato chips. You could dump salt into your body and you would get hypernatremic from eating too much salt. Your body's really good at sort of metabolizing salt. What your body isn't that good at is figuring out what to do with fluids. And if you don't get enough fluids, you become super dry. And that's the most common reason people are hypernatremic, which is defined as a sodium over 145. Most people never get there because you're thirsty. So you start to get dehydrated, you go get your sodium starts to go up, you go drink some water. So it makes sense the people who get hypernatremic are the people that either don't know that they're thirsty, because they're busy responding to internal stimuli because they're a schizophrenic, or they're too little to get there like a kid, or they're too old to get there, or infirm, or some reason people can't get to water. Most of the time, even if somebody has a sodium of 150 or 155, they don't really have any significant issues except maybe thirst. You start to get in trouble when the sodium really gets about 160 or higher. And you're going to find that when it comes to electrolytes, there's normal, there's outside the range of normal a little bit, which is something we need to worry about, but not particularly problematic for the person. And then there's outside of the range of normal a lot of it. And that's where we need to get involved. So when you start to get really, really dry, your sodium going up to 165, 170, you get lethargic, you get altered, you won't eat because you just feel terrible. That's the symptoms that you tend to have. And most of the time, all you really need to do is give them water. Let them drink. Okay, if someone can drink, oral hydration is fine. And you titrate yourself. Your body's smart. It'll turn off your thirst when you're done. If you need to bring it down by your intervention, normal saline is fine. Remember, often they got there because they're dehydrated. So their volume deplete. What you're going to give them with normal saline is 154 milliequivalents a liter. If they're 170 milliequivalents in themselves, you're hyponatremic to them even with normal saline. So usually what you need to do is tank them up some. Don't go crazy normalizing that sodium, because remember, once the sodium is down to about 160, the symptoms should minimize. There's no hurry to get it down to 140. In fact, you can do harm if you bring it down too fast. People make it, if they're hypernatremic for a long time, their brain actually gets these internal osmoles. And now you add a bunch of fluid and it makes the brain swell. And you can end up with basically cerebral edema from this. So don't go crazy. Your goal is to get that sodium about 160, 155, get it there about a milliequivalent an hour. Most of the time, it's completely fine to give normal saline, and you're good to go. So hypernatremia, again, you're going to find a theme in this, which is don't make it normal, just make it where it's in the range where they should feel better and let them, over time, get better. No more so than with hyponatremia. Now, hyponatremia is complicated. There are three flavors of hyponatremia, three versions of this. One is hypervolemic. I have too much fluid all the way around, so I'm kind of diluted. That's the CHF-er, the cirrhotic. There's the hypovolemic hyponatremia. That's the person on diuretics. So I'm peeing out water and I'm peeing out sodium because of the diuretic that I'm on. And it's more sodium than water, and I end up hyponatremic. So I'm dehydrated, but I'm hyponatremic. And then there's euvolemic hyponatremia, which tends to be associated with illnesses. Brain problems and lung problems in particular, pneumonias, lung cancers. It's usually SIADH related. Okay, so there's basically a syndrome of inappropriate antidiuretic hormone. Those people have normal volumes but low sodiums. The reason it's important to tell the difference between them is that your treatments will differ depending on what's causing them to be a low sodium. The other thing to know, just like on the high end, on the low end, the range of normal of sodium is down to 135. You can have a sodium of 128, and you're usually fine. You usually don't see symptoms at all till 125. And I have to tell you, if you see somebody who's twitching or altered or seizing, or you think symptoms might be attributable to hyponatremia, but their sodium is 128, that's not the problem. You usually don't get symptoms till you're 125 or less. And on the flip side, if you're bringing somebody up who's really low, by the time they hit 125, they should feel better. So watch those numbers. 125, you get to just kind of sit back and relax. Things are cool. Okay, 125 is kind of the goal we're looking for. And the symptoms they get is they get nausea, they get a headache, and as they get lower, they can have things like seizures. Now, the other thing to know is that your hyponatremia symptoms are dependent on how quickly you got there. So the sickest people I see with hyponatremia are children given free water as a rehydration fluid when they're dehydrated. Dilute tea is sort of a Hispanic, dilute tea with sugar is something that they often will, in our Hispanic population, rehydrate their children with at home. But the problem is that's free water and no salt. And these kids will basically get dilute quickly, and they'll come in seizing with a sodium of 110. But they got there in half a day or a day. That's why they're so sick. If you get there over weeks, my sodium's 118, but I have cirrhosis and I've had this extra fluid on board forever, I'm less symptomatic because it took me a long time to get there. My body is more used to it. It's really important because we can do harm trying to bring up a sodium too quickly. We can do really terrible harm if we do this. So because most of the time people are hyponatremic because there's too much water on board, all you need to do is fluid restrict them. Okay? Most of the time, all you do is say, no more water for you. No more water for you, done. You don't, unless they're super dehydrated, you don't need to give them normal saline. Okay, if they are, you can give some, but don't correct them too quickly. Your goal, unless they're seizing or altered or comatose, your goal is to bring them up about 0.5 to 1 milliequivalent per hour. Why do I care? Well, it turns out there's this nasty entity called central pontine myelinolysis. Very complicated. It sounds like, what is this long term? What you basically do is demyelinate parts of your central nervous system, often your spinal cord. Often, unfortunately, your basal part of your brain. And what can happen, and you won't see it in the ER. Yay for me, they came over the sodium of 118, now it's 135, don't I rock? But then tomorrow morning is when they get the CPM symptoms. And they'll get things like locked-in syndrome. They will demyelinate their high spinal cord. They will be basically in there and no way to move, no way to breathe. It's horrendous. Please do not go crazy overcorrecting hyponatremia. Don't do it. You don't need to do it. And again, 125 is the magic number. And how quickly they got low is going to really determine what you do for them and how sick they are when they get there. Seizures and coma push your hand a little bit. Otherwise, if they're just feeling a little lethargic, a little gross, don't go crazy. Okay, 0.5 to 1 milliequivalent per hour max to raise them up. And fluid restriction is probably the best way to start. Now, hyperkalemia is fun. We see tons of hyperkalemia. Most often it's in a renal failure patient, and they actually, to be honest, can handle a little bit of hyperkalemia because they live there a lot. If they get dialyzed every third day, their potassium kind of creeps up, and then it's Wednesday and it gets dialyzed down, and then it creeps up, and then it's Friday and it gets dialyzed down. They can handle potassiums up to 5.5 pretty well without too much trouble. But if you put me on an ACE inhibitor, I've never had one before. I actually have some renal dysfunction you didn't know about, and now my sodium, or my potassium can go to 7 to 8 acutely. That's another big reason people get hyperkalemic is from ACE inhibitors. Often they'll do that, and they'll have potassiums that are really high. Our job is to basically figure out, are they having trouble from that elevated potassium? And the part of the body I care the most about is your heart. Because hyperkalemia can kill you, and it can kill you quick. And it does a couple weird things. It can make you go from normal sinus rhythm to asystole, like that. It can make you go to a sinus bradycardia that doesn't respond to anything I try to give you, like that. It's remarkable. So what you want to do is, the money is in the EKG. So if you get a potassium back that's 7, the first thing you want to order is an EKG. And what you want to do is look at what changes on that EKG. And the best way to think about this is first thing you do is you pull up that T wave. And if you ever see a T wave that looks like it would hurt to sit on, really pointy T wave, that's almost always hyperkalemia, almost always. Then what happens as the potassium goes higher and higher and higher, it's like pulling the string. So you take your EKG and you're pulling now either end of it out. The first thing that happens is my PR gets longer. Then I keep pulling, my P wave disappears. Then I keep pulling, my QRS starts to widen. And if I really pull far enough, I get a sine wave, which doesn't perfuse you very well to have a sine wave. That is sort of the progression of hyperkalemia. And anywhere in there, you can have sinus bradycardia or asystole. Anywhere in there. So those are two kind of weird things that you don't learn about much in school, but it is clinically quite relevant, and you see it quite a bit. So those are your EKG changes, and the reason you need to know that is it's going to determine what you do about treating that hyperkalemia. So if I have somebody with potassium of 5.8, I get an EKG and it looks totally normal, I don't go crazy. I have somebody with a potassium of 7.5, and they have a wide QRS, I find no P waves anywhere, that person gets the works. If I need to treat them, and a peaked T alone, that I don't want to sit on it, T wave, is not what you're going to treat. Okay, that in and of itself is not going to kill anybody. But they start to prolong their PR, they lose their P wave, now you need to do something. And the best thing to do to help the heart right now is to give them calcium. At the heart level, it's an antidote, basically, for hyperkalemia at the heart level. It will take away all of the effects that you're worried about that would kill somebody from hyperkalemia. So EKG changes more than just a peak T. Anything beyond that, more than just a peak T, please give calcium. Okay, please give calcium. If you ever see sinus bradycardia in a renal failure patient and you cannot figure out why they're sinus bradycardia, or you see a bradycardic arrest in somebody who's a dialysis patient, push calcium. Okay, it is often related to hyperkalemia. Now that helps the heart right away, but I have other things I can do as well if somebody's K is really high. We know that you can give insulin and glucose. You know you can do that. You can actually give insulin that shoves, using glucose as a substrate, it shoves potassium into cells. So it takes what's in your serum and it shoves it into your cells. Now it takes about 5 minutes or so to work. It only lasts about a half an hour, but you do get that window of time. It eventually will come back out again. You do get that window of time. You can give bicarb. Acidosis basically pushes your potassium pulls your potassium out of cells. I give bicarb, I make somebody alkalemic, it pushes potassium into cells. Great. You can give albuterol. Beta adrenergics make people push their potassium into cells. So you have that person with that scary EKG. You get RT to put them on a nebulized mask of albuterol. You push the calcium. You've already done 2 huge things really fast that could drive potassium into cells. And then and all of the things we just did, either the calcium blocks potassium at the heart, the effect. All the others shift potassium into cells. The way to get rid of potassium, especially in somebody who can't do it through their own kidneys, is to use something like K-Exolate. Now, I'll tell you, K-Exolate's getting bashed in the literature right now. There are a couple of studies that just came out looking at, does it really do what we think it does? And is there any downside? It turns out it probably does do what we think it does, but not as well as we think it does. And there is a downside. You should never give K-Exolate to somebody who's had a renal transplant. It turns out that that particular, and the elderly is another group, but that particular group of patients, what can happen to the K-Exolate is it becomes basically concrete in certain parts of the bowel, particularly the colon, and it can cause colonic necrosis. And there have been enough deaths reported that is probably something I would never give it in a renal transplant patient, and a renal transplant surgeon or nephrologist will go ballistic if you give it, because it does run the risk of necrosing their bowel. Overall, though, for most people, it's fine to give. It takes a while. They have to poop it out to get rid of it, and it probably doesn't do quite as much as we'd hoped, but it's one of the only ways to really get rid of potassium if it's high. What about the low end of potassium? Hypokalemia. This is usually a body loss problem, usually diuretics. You put somebody on Lasix, they will pee out potassium. It's usually diuretics. It's usually renal losses. It can be from GI losses. That's much less common. It's usually renal losses. It's not common for it to be diet related. If you eat anything in the United States, you're going to get enough potassium to have enough in your diet, as long as you're not on something that actually makes you pee it out. Now, there are some really cool entities out there. Let me tell you a story. I have a resident he just graduated, thank God. He was driving me crazy because he's one of these kind of prove to me you're sick kind of guys, which is just not the kind of person to be in an ER, I tell you. And he came up to me and he said, for the umpty gazillionth time for another patient, I got this malingerer in the back who won't get out of bed. His family brought him in because the guy will not get a job. They're pissed off at him. All he does is sit around in the living room, watch television. Sometimes he slides out of the chair on the floor. They just step over him. And they brought him in because he won't get out of bed. So that's weird. Really? I said, did you do a neuro exam? He said, no, he won't cooperate. Fine. Go examine this guy. He's a young guy who had, first thing I noticed is that he had proptosis. I'll tell you why that's important in a second. Went to examine him. He couldn't lift his leg off the bed. He couldn't lift his arm off the bed. He couldn't lift his head off the bed. I said, what did you have to eat today? He said, I love ice cream. In fact, I eat ice cream almost all the time. That's what I eat. I love ice cream. Interesting. We got I turned to the resident. I said, get an I-stat. I said, get a rapid potassium level now. 0.9. What he had is periodic paralysis. And he had a hyperthyroidism-related periodic paralysis. There are certain people, there's a Mediterranean version of this, there's a hyperthyroid-related version of this, and then there's a familial version of this, where what they get is, usually it's based on some sort of carbohydrate load, hence the ice cream. They get a glucose release in their own body to metabolize the ice cream, but the problem with that is what happens when you give insulin. You drive your potassium into cells. These people get an exaggerated response to that, and the reason the guy kept sliding out of the chair in the living room on the floor after he ate ice cream is because he had no potassium. Now, what's interesting about those people is you don't need to replace their potassium. You wait. Okay, they will come back on their own. And in fact, if you replace their potassium, you run the risk of overshooting at the other end. But it's one of those kind of cool entities. So if somebody ever tells you, God, it's so weird. Every time I eat, an ice cream cone, I get really weak. That's interesting. I think that's interesting. It's fascinating. It's a fluid shift. Hypokalemia in general isn't that exciting, though. In general, it's related to diuretics. That's what we tend to see. And what you basically need to do is replace it. The easiest way to replace it is give it to them orally. Okay? Just give it to them orally. So have them take something orally. It works. It's beautifully absorbed. There's no worry about, oh, how much do I give IV, and do I need a central line, and how quickly can I give it? You don't have to worry about that. If they're severe, though, if it's somebody who is on a diuretic and their potassium is 1.9 and they're weak and they're feeling nauseated and you can go ahead and give it IV, and you can give it together. You can give it together. It's easy to fix. Now, a couple things to know. Often people who have hypokalemia have hypomagnesemia. Put those two electrolytes together in your head, because you'll have trouble replacing the potassium if their magnesium isn't enough, if they don't have enough magnesium. So when you really have somebody who's significantly hypokalemic, consider just giving them mag in addition. Okay, just giving them mag. We'll talk about mag in a second. So here's some ECG changes you'll see with both. Remember the hyperkalemia, it's that peak T, then you lose your PR gets longer, you lose your P, and you stretch out your QRS. You're pulling the string. Hypokalemia is not quite as exciting, but every once in a while you get to see what's called a U wave. So I get to see that every once in a while. How about your calcium? Calcium's interesting. Hypercalcemia is virtually always related to cancer. Okay, you can have hyperparathyroidism, truly parathyroid gland problems, but that's actually pretty uncommon. Cancer is far more common, and the cancers that tend to cause this are the ones that produce a hormone that your body thinks is parathyroid hormone. It's a parathyroid-like hormone complex that's produced by the tumors. And the tumors that do it, the mnemonic to remember them is bacon, lettuce, and tomato with a kosher pickle and mayo. So it's a sandwich. Breast, lung, thyroid, kidney, prostate, multiple myeloma. Bacon, lettuce, and tomato with a kosher, pickle, and mayo. Those are the tumors that tend to cause hypercalcemia. And what these people will come in with, think about it. I'm a cancer patient. I have lung cancer. I come in and I say, I'm really tired. I'm a little confused. I'm fatigued, I'm constipated, I'm nauseated all the time. Well, of course you are, you have cancer. Ha ha. A good practitioner will say, really? It might be your cancer, but let's check a calcium. Because it turns out that hypercalcemia causes constipation, lethargy, maybe a little bit of confusion. The higher it gets, more confusion. If you pick that up, what's nice about it is that you can make them feel better fast. There was a heartbreaking study that they published looking at cancer patients in the hospital, admitted, like in the hospital, who had documented hypercalcemia on their labs that just got kind of ignored. But if you treat them, you hydrate them, they feel scads better. You make them lots and lots better. So hypercalcemia, which is just so, and there's this whole ionized thing and albumin thing. If it is high, it's high. You correct it, it's still high. High is high. Low is different. High is high. I don't care what your albumin is. I don't care what's ionized. High is high across the board. What you'll see on an EKG, if you get one, is a shortened QT interval. Hypercalcemia shrinks your QT interval. It makes it short. So it's kind of, next time you see somebody with hypercalcemia, go look at their EKG. It's quite common that their QT is shortened. And the best way to treat this is hydrate them. Give them fluids. Often that's all you need to do in the ER to take care of their symptoms. You get them hydrated, that dehydration is gone, it dilutes them down, it helps them pee out some of that calcium, it makes them feel much better. All the other stuff, which includes things like salmon calcitonin or some of the bisphosphonates, honestly, you do not need to do. You're an emergency person. You don't do that. That's done down the line. It takes a while anyway. You give hydration. They feel tons better. Now, hypocalcemia, low calcium, the flat out most common cause is actually not on this slide. It's renal failure. Renal failure, because of things that it does to your calcium and phosphate metabolism, causes hypocalcemia. All the other things do too. Parathyroid hormone deficiency, if you're not going out and gardening enough and you have a vitamin D deficiency, all of those can cause it as well. But flat out, most commonly, it's renal failure that causes this. You could do this to yourself right now, by the way. If you were to hyperventilate, we talked about the other day, you hyperventilate, you wouldn't breathe again for a while because your respiratory drive, you've blown off all your CO2. You can do that. You may have done this in your grammar school out playing the playground. You sit around and you take huge deep breaths. What you do is you shift your ionized calcium, and you can give yourself all of the symptoms that go with hypocalcemia. Carpopedal spasm, tingling in your fingers, tingling around your lips, twitches. I can tap on here and I get facial twitches. I can put a blood pressure cuff on and I get spasm in my hand. All of those are signs of hypocalcemia, and you can do it to yourself by breathing really fast and shifting your ionized calcium around. Somebody who's hypocalcemic because they just don't have enough in their system will have the symptoms that come in with this. If you want a mnemonic, there's one called cats go numb. Basically, they can seize, they get dysrhythmias, they get tetanus. Somebody takes their blood pressure and their hand goes like this. You have to worry that they have hypocalcemia. The treatment for this basically is replace it. You can do it orally, you can do it IV. One little caveat about IV calcium, whether you're using it to treat hyperkalemia or to replace hypocalcemia, make sure your line is patent. Make sure it's a really good line. Don't put it in that little thing that they stuck on the thumb with a 22 gauge. Don't put it there. Because if it extravasates, it can necrose tissue. And there was a $5.4 million lawsuit settled for somebody who lost an arm because of extravasation of calcium that probably, to be honest, and looking at the case, didn't even need to be done. It wasn't really necessary. So just make sure that when you push calcium, the line is good. Often they can take it orally. So that's hypocalcemia. And then, the other thing, one more thing about it. Hypocalcemia in a renal failure patient. Often they're a little hypocalcemic anyway. They tend to tolerate it fine. If they're asymptomatic, leave it alone. If they're symptomatic, before you give them any calcium, look at the phosphate. There's a thing called the calcium phosphate product, where if you take the calcium and the phosphate level and you multiply them times each other, if that ends up more than 60, you run the risk of metastatic calcifications, basically calcifying parts of your body spontaneously, because you have enough of both to basically make a little stone somewhere. It can be in your tissues, it can be in your anywhere. You can calcify. So their phosphates are often high. So if you have somebody with a calcium of 4 and a phosphate of 12, okay, that multiplies at 48, I'm probably okay. But if their calcium is 6 and their phosphate is 12, now if I give them more calcium, They run the risk of metastatic calcification. So renal failure patients, just be a little bit careful. Don't go after treating a number. Remember, you're treating the whole patient anyway. And if you do need to treat it, check that phosphate first and make sure that your multiplier of those isn't over 60. The last electrolyte we're going to talk about, I think, is hypomagnesemia. This is not that common, to be frank. It tends to be people who are poorly nourished or alcoholics. Alcoholics have it a lot. People, if you don't use food as your calorie source, so if you either don't have calorie source or you drink your calorie source, you don't get enough magnesium in your diet. And you may end up hypomagnesemic as a result. You can have it from GI losses and renal losses. That's much less common. It's usually that you just don't ingest it enough. And it tends to be people who use the wrong things or don't eat. Use the wrong things to eat or don't eat. The problem with magnesium is that 99% of it in your body right now is sitting in your bones. Okay, it's not sitting in your serum. And the serum measurement tends to be somewhat of a poor measure of whether you're truly hypomagnesemic or not. So it is worth assuming any alcoholic is hypomagnesemic and anybody who's malnourished is hypomagnesemic. The symptoms are actually very similar to anybody who has hypokalemia. They feel kind of queasy, they feel kind of weak. Remember, calcium and magnesium go together. So if you replace the magnesium, check that calcium. You often need to replace the calcium too. So those kind of go together. ECG manifestations are very similar to low potassium. The treatment, again, is oral for the most part. Now, a couple things about this. We give people magnesium orally on purpose to make them poop, right? Milk of magnesia, you do it on purpose to make them poop. It's a good, you absorb it, you'll absorb it nicely, but you'll also have diarrhea. So if you need to replace somebody's magnesium orally, these low, sort of slow release formulations are a little easier to tolerate because they don't end up having diarrhea. So they're easier. You can also give it IV. The thing about giving magnesium IV is pushing it makes people flush and throw up. It's rare that you ever have any reason, at least as a replacement of the low magnesium, to push it. Do it as a drip. Put it in over 20 minutes. Put it in and just throw it in an IV bag and put it in over a couple hours. There's no magic to this. And most, for instance, alcoholics should probably get replaced because they don't have enough in their serum. It's all been shifted around. Now, hypermagnesemia is rare. This is renal failure patients. Your body is really good at getting rid of magnesium as long as your kidneys work. If you have too much, it gets rid of it, or it sticks it in your bones. It's actually fine. It shifts it around for you. But if your kidneys don't work, that's the time you can get hypermagnesemic. Otherwise, it's extremely uncommon to get hypermagnesemic. And if they get it, if they're hypermagnesemic, they'll present just like the person you push it in. Flushed, nausea, vomiting, that's how they'll present. It's extremely uncommon for this to happen, extraordinarily. And all you really need to do is get them to pee it out if you can. So here's a summary slide of all those electrolytes. They are actually fun. And my take home on these is don't make somebody euboxic. Okay, get them in the range where their symptoms should be ameliorated. So don't go crazy, make them normal, because you can do some harm. And pay attention to the 12 lead. The 12 lead gives you a lot of information, particularly on hyperkalemia. All right, I'm done with my lectures. I think Rick's going to come up, and we'll have the panel at the end. You guys rock. Look how many people are here. You guys rock. This is great. Thank you.